Hello, my name is Dr. Minde, and in this lecture series, I'm going to discuss the gross anatomy of the large intestines. And so, remember from the small intestines, food now moves to the large intestine. What are the functions of the large intestines? There's absorption of water, then converting the liquid chyme from the ileum into semi-solid stool or feces, and then to store the feces temporarily until the urge for defecation. So the large intestine contains the cecum, the appendix, the colon, which has 4 parts: the ascending colon, transverse, descending, and sigmoid colon. Then you have the rectum and anal canal. So how do you differentiate the large intestines from the small intestines? The large intestines contain omental appendices. Omental appendices are small, fatty, omentum-like projections. So just projections from the omentum. Remember, the omentum is the apron-like peritoneal modification, just deep to the anterior abdominal wall, and you have greater omentum and lesser omentum. So it's the greater omentum that's apron-like, and it runs from the greater curvature of the stomach downwards towards the transverse colon, while the lesser curvature is from the liver to the stomach. So omental appendices are small fatty omentum-like projections, and large intestines also has tinea coli. Tinea coli are thick bands of smooth muscles, and they run longitudinally. So large intestines have 3 tinea coli. Then the presence of haustrations. What are haustra? Haustra are circulations of the colon wall, which are found between the tinea. Circulations of the colon wall found between the tinea. Large intestines also have a greater caliber, which is the internal diameter greater than the small intestines. So this image just shows you that's the cecum, the ascending colon, transverse colon, descending colon, sigmoid, rectum, and anal canal. And these are the haustrations here. And these longitudinal fibers, smooth muscle fibers, these are the tinea. Okay? Appreciate the haustra. Look at the omental appendices. Omental appendices are also called epiploic appendages. Look at the tinea coli here. So between the ascending colon and transverse colon, that's the hepatic flexure. And between the transverse colon and descending colon, we call that the splenic flexure because it's close to the spleen. This one is the hepatic flexure because it's close to the liver. So you can appreciate here tinea coli, longitudinal, smooth muscles. These are the haustrations, and you can appreciate the semilunar folds and the appendices, omental appendices or epiploic appendages. So tinea coli, the longitudinal smooth muscles, they begin at the base of the appendix as a thick longitudinal layer of the appendix. They begin from the base of the appendix, and usually they split to form 3 bands. Remember, the appendix is very narrow. So they begin from the base of the appendix, but later on they will split into 3 bands. And these 3 bands include mesocolic band, omental band, and a free band. The mesocolic band is where the transverse and sigmoid mesocolons attach. Mesocolon are mesenteries of the colon. So the mesentery of the transverse and that of the sigmoid colon. Okay, so that will be referred to as the mesocolic tinea. Okay, so where the mesocolon of transverse and sigmoid colon will attach. Then you have the omental tinea band, where the appendices, omental appendices attach, and then you have a free band where no mesocolons insert onto and no omental appendices are attached. So you can see an omental tinea because omental appendices are attached onto it. Then the one that has no mesocolon attached onto it will be a free tinea band. So the tinea coli, they run through the whole length of the large intestines, and at the rectosigmoid junction, they merge again. Remember, they were merged at the base of the appendix. At the rectosigmoid junction, they merge again into a continuous longitudinal layer around the rectum. They are usually shorter than the intestine. Therefore, if they are at the side and they are shorter, while the colon itself is longer, they will now make the colon look circulated, and these circulations are what we call the haustrations, the haustra, circulations between the tinea muscles. So this is what we are referring to. These are the omental tinea there, where omental appendices attach. Then this is your appendix here, so this is where the tinea will begin. These are the omental appendices. So you can appreciate semilunar folds here. This is the omental tinea. This is the mesocolic tinea, and the transverse mesocolon is here. you can appreciate the greater omentum and the prostrations together with the omental already discussed. So we proceed to the cecum. Yeah. So the cecum is the first part of the large intestine. Cecum is the first part, and from cecum we continue. The colon continues, ascends upwards as ascending colon. So the cecum is just a blind pouch and measures 7.5 in length and 7.5 in breadth. It's located in the right lower quadrant, mainly in the iliac fossa. This cecum is inferior to the junction of the terminal ileum. Yeah, the location is inferior to the junction of the terminal ileum and the cecum. So if distended with feces or gas, the cecum may actually be palpable on the anterolateral abdominal wall, and you can locate it within 2.5 centimeters of the inguinal ligament. So the cecum is almost entirely enveloped by the peritoneum. However, it has no mesentery that attaches it to the posterior abdominal wall. It has freedom, relative freedom. Therefore, it can move, it's mobile, and it may actually be displaced from the iliac fossa. Commonly, it's bound to the lateral abdominal wall by cecal folds of the peritoneum. So this is the position of the cecum here. This is the cecum, and it's from the cecum downwards you'll get the appendix. So from ileum, food enters. This is the opening of the ileum here. This is the cecum. So the terminal ileum usually enters the cecum obliquely and then partly invaginates into it. You can see the terminal ileum partly invaginates into the cecum. So that produces an ileocolic lip. There's a superior ileocolic lip and an inferior ileocolic lip there. These are at the ileal orifice and they form the ileal papilla. So the folds meet laterally to form ridges, and these ridges are the frenula of the valve. Okay, so you can see superior lip, inferior lip, so they meet laterally to form the frenulum of the ileocecal valve. So this is the ileocecal valve. So they form the frenula of the ileocecal valve. When the cecum now contracts or distends, the frenula tighten, so they close the valve. Because when the cecum contracts, we need the material in the cecum to go to the ascending colon, not to go to the ileum. So when the cecum contracts or distends, the frenula now tighten. Yeah, this frenula here, they tighten, then close the valve so that food from here can move to the ascending colon other than moving backwards to the ileum. So, so you prevent reflux into the ileum. Poorly developed circular muscles around the orifice. The orifice has poorly developed circular muscles, and the valve is unlikely to have any sphincteric action that controls passage from the ileum. The orifice is usually closed by tonic contraction, and the valve prevents reflux from the cecum to the ileum as contractions occur to propel food to the ascending colon. So, the appendix. From the cecum, we go to the appendix. The appendix is just a blind diverticulum of the intestine, a blind intestinal diverticulum that measures 6 to 10 centimeters. So the length varies in different people, and it contains lymphoid tissue, masses of lymphoid mucosa-associated lymphoid tissue, a lot. And it usually arises from the posteromedial aspect of the cecum in majority, and lies inferior to the ileocecal junction. The appendix has a mesentery called the mesoappendix that is short and triangular in shape and originates from the posterior part of the mesentery of the terminal ileum. The mesoappendix attaches the cecum and the proximal appendix. The position of the appendix is variable in different people. Majority of the population have a retrocecal, an appendix behind the cecum. The base of the appendix lies at the McBurney's point. Where is the McBurney's point? When you join a line from the anterior superior iliac spine on the right side to the umbilicus, okay, anterior superior iliac spine to the umbilicus, a third of that line from the anterior superior iliac spine, that is the McBurney's point. So a third of the oblique line along the oblique spinoumbilical line is the McBurney's point. So this image just shows you the different positions of the appendix. It could be retrocecal, okay, at 11 o'clock. It could be post-ileal, pre-ileal, pelvic in the pelvis, subcecal below the cecum, paracecal parallel to the cecum. So these are the different positions. Subileal parallel with terminal ileum, pre-ileal anterior to the ileum, post-ileal posterior to the ileum, retrocecal behind the cecum. So majority of the people have a retrocecal appendix. This just shows you that the appendix has a mesocolon, as a mesentery, and this mesentery is the one that carries the blood vessels to the appendix. So you have appendicular artery from ileocolic that's coming within the mesentery to supply the appendix. You can appreciate this is the appendix and this is the mesoappendix. This shows you the Mark-Barnes point. Okay, we said from the anterior superior iliac spine on the right to the umbilicus. So as you draw from assist to umbilicus, the first a third, that is the point, the Mark-Barnes point. So anterior superior iliac spine to umbilicus, a third way from anterior superior iliac spine to umbilicus, not a third from the umbilicus, it's a third from the down, from the lower portion, from anterior superior iliac spine to umbilicus, and that gives you the position of the appendix. Okay, so this side is 2/3, then this towards the axis is a third. Remember, the appendix is mobile, mainly in the right lower quadrant. This image just shows you the lymphatic nodules in the appendix. We said it's a highly lymphoid organ. So all these are lymphoid tissue within the submucosa of the appendix. This is the mucosa. This is the submucosa of the appendix. What's the blood supply to the cecum and the appendix? The cecum receives from ileocolic artery, which is the terminal branch of superior mesenteric artery. And the appendix receives from appendicular artery, which is a branch from ileocolic artery. Ileocolic vein now carries blood from the appendix and cecum upwards to the superior mesenteric vein, which will be joined, will eventually drain to the portal vein. So it's the superior mesenteric vein and splenic vein that form portal vein. Then we have lymphatic drainage of the cecum and appendix. So we have lymph nodes in the mesoappendix that will carry lymphatics from these two, then drain the lymphatics into ileocolic lymph nodes that follow the ileocolic artery. So this just shows you appendicular artery from ileocecal artery. You can see the ileocecal artery going to supply the cecum. You can appreciate ileocolic here, giving branches to the cecum anteriorly and posteriorly, and from the mesoappendix you can see your appendicular artery. You have to remember that the appendicular artery is in the mesoappendix, so that during surgery you have to identify the mesoappendix so that you do not cut the appendicular artery. So what's the innervation? You have sympathetic and parasympathetic following the superior mesenteric plexus. So sympathetic is from lower thoracic part of the spinal cord, while parasympathetic is from vagus. Now, afferent fibers from the appendix, like pain fibers, they usually accompany sympathetic nerves to T10 segment. So information about pain from the cecum will get to T10. Will be referred to, the information will be carried to T10 segment of the spinal cord, and then you'll get referred pain. So what is appendicitis? Appendicitis is acute inflammation. Anything itis means inflammation. So appendicitis is acute inflammation of the appendix that leads to acute abdomen. Acute abdomen is just sudden, severe abdominal pain. Having abdominal pain that starts suddenly and is very severe. So appendicitis is characterized by tenderness over the Mark-Barnes point. Tenderness over the Mark-Barnes point. What are the causes of appendicitis? In the young, you'll find a hyperplasia of the lymphatic follicles. I've said the submucosa has lymphoid follicles. So when there's hyperplasia, increase in number of these cells in the lymphoid follicles, it causes appendicitis. While in the older people, appendicitis is due to obstruction due to fecalith. Fecalith are also called coprolith, and these are just concretion around fecal matter. So when you have concretion around fecal matter, they obstruct the lumen of the appendix, and that obstruction causes the appendix to swell, and then it stretches the visceral peritoneum, leading to pain. Remember in the lecture about peritoneum, we said the visceral peritoneum really does not respond to pain, but this pain will eventually be referred. So you feel it as sort of referred pain. What are the symptoms of appendicitis? Initially, you get a vague periumbilical pain. So there's referred pain at the periumbilical region, which has a dermatome of T10 because the afferents of the appendix were being carried to T10 portion of the spinal cord, and that is also the dermatome of the periumbilical region, T10. Later, the patients get severe pain in the right lower quadrant, okay? And this severe pain is because of the parietal peritoneum has been affected. Then when they extend the hip, there is pain. What are the complications of appendicitis? Infection begins, leading to thrombosis of the appendicular artery, then ischemia and gangrene of the appendix. After it undergoes ischemia, the wall undergoes ischemia and gangrene. There is perforation and rupture, leading to peritonitis because infection now enters the peritoneum. The peritoneum becomes inflamed, leading to abdominal pain, nausea, vomiting, and rigidity of the abdomen. But the patient usually says when they extend the hip, they feel pain. But when they flex the hip, the pain reduces. Why? Because during flexion, the right psoas muscle is relaxed. So they feel that the pain is less. So this just shows you, this is the appendix here. And you can see fecalith obstructing the lumen. This is the normal appendix, and this is an inflamed appendix. There's a fecalith, calcified fecal deposit here, and the wall is inflamed and the appendix is enlarged. So appendectomy is when now you do an operation at the McBurney's point. You put a transverse incision so that you identify the appendix. How do you identify it? You get the tinea coli where they converge. That's where you look for the appendix. Because remember, we said the tinea begin at the base of the appendix. So where the tinea converge, that's the position of the appendix. So if the appendix is not obvious, you'll just look for the tinea coli and trace it to the base. Then look for the mesoappendix during surgery and firmly ligate the appendicular vessels because appendicular vessels are in the mesoappendix. So thank you very much. In the next lecture, we will discuss the colon. So that's basically about the cecum and the appendix and the clinical aspect about the appendix. Thank you.